You are watching a POZ and AIDSmeds.com video from the 2008 Conference on Retroviruses and Opportunistic Infections in Boston, Massachusetts.
Hi, this is Regan Hofmann, Editor-in-Chief of POZ Magazine, and I'm here this morning with Professor Bernard Hirschel from the University of Geneva, Switzerland. Thank you for coming with us this morning.
Well, you're very welcome.
And we're here to talk about a statement that was issued recently by the Swiss Commission on HIV and AIDS. And Dr. Hirschel was one of the co-authors. There were 3 other authors of the study, is that correct?
That's right, two other authors.
2 other authors, okay. And so there's been a lot of controversy. I mean, the basic premise, if I may, of the study was that, the statement, which was based on an analysis of several studies over a long period of time, is that an HIV-infected person on antiretroviral therapy with a completely suppressed viral load for more than 6 months is not technically sexually infectious. Is that true?
That's right. No virus, no infection.
No virus, no infection. That's a big, bold statement, and that has really rocked the community. There's a lot of discussion on both sides of it. I guess before we get into the specifics, can you tell us why the Swiss Commission decided to issue this study now, or this statement now?
Okay, there are several reasons. The first is a series of trials in Switzerland where people were accused of endangering others by sexual relations. They were HIV positive, the partner was HIV negative, and the defense said, well, there was little or no danger because my client was treated and he had undetectable viremia. Right. This defense was not admitted based on official statements saying that treatment did not influence or had little influence on infectivity. Right. And that's just plain wrong, and there needs to be some official statement to the contrary.
Gotcha.
Now, the second reason is revolves around couples who want to have children. Mm-hmm. If the man, for instance, is HIV positive, the woman HIV negative, some go to extraordinary lengths to avoid exposure to HIV by doing in vitro fertilization and ovulatory stimulation, and then have this way implantation of an embryo and all that. Now, that's all good and fine, but there are several problems. First of all, very expensive. Right. Second, not very efficacious with pregnancy rates that are low. And third, the ovarian stimulation causes multiple pregnancies, and they are risky to the children, to the newborns.
Gotcha.
So you exchange a theoretical, probably inexistent risk of HIV infection against a very real risk of injury to the unborn child, and that's really a problem. So you have to say something about that. Then there are other reasons. If you look at the general picture about prevention, you have condoms. That's it. Right. You don't have vaccines, and we won't. Right. And microbicides are way off in the future. Right. All right. So what else can we do? And I think we need to think about other means of prevention, and treatment is such a weapon against future HIV infections. Right. And you cannot very well defend the point of view that we should treat additional people, not only for themselves, but also for prevention of additional infections, while maintaining that treated people are still infectious. So there's a real problem there of logic.
Right. So you're saying, for example, I know I've had, I am HIV positive myself, and in a serodiscordant relationship, one of my future hopes was PrEP for my partner, potentially. For example, if I wanted to conceive naturally, then I would think about down the road if PrEP were proven to be effective. But what this gives us is another option. So if I'm carefully monitored, perhaps have no viral load for more, haven't had one in the last 6 months, then really this could be as theoretically effective as PrEP, if PrEP were to be proven to be 100% effective.
Yes, okay, that's true. Right. I mean, you could also, the individual decisions have to be distinguished from public health recommendations. Right. As an individual, you may really want to put all the chances on your side, and you may want to have suspenders and a belt, and have PrEP plus undetectable viremia. Right. That is a choice that you can make as an individual, but very probably the risk to your partner in such a situation is nil or negligibly small. Right. And therefore, many couples, of course, do have children, the usual way.
Right. And it's also, in a way, added insurance. So, for example, even if you are practicing safe sex, you use a condom, and you're on treatment, your viral load suppressed, and the condom breaks. This is also a situation where you might be able to feel a little bit better about not potentially having infected your partner.
Of course, you get all these people who are potentially exposed to HIV, who are panicking, who want post-exposure prophylaxis or PEP.
Right.
Now, the thing is, we do not give PEP if the exposing partner has undetectable viremia. I mean, we do it if somebody absolutely goes crazy if we don't.
Right,
but anyway, we don't recommend it because we do not think that the risk is worth the expense and the potential side effects of PEP. Because if you multiply the probability of infection by the costs and whatever, you get absolutely astronomical sums. I don't think it's a good expense of limited healthcare resources to do that.
Well, and that's the point today, because when we talk about how many people globally are living with HIV and AIDS and maybe soon to be infected or tested soon and find out. I mean, we're not only dealing with how do we control the virus and how do we treat those with the virus, but the sheer volume and the sheer cost of these treatments. So things like this that would help reduce, a double treatment or an unnecessary treatment would certainly be appealing. The practical question I've been asked a lot is, okay, so how do I know that my viral load is undetectable at any given time? I mean, if I was at my doctor, had my regular lab work done, say several weeks ago or even 3 months ago, and it was undetectable, and I choose to have unprotected sex in a serodiscordant partnership, is that safe? Do I need to go get a new viral load test 10 minutes before every time I want to be with someone, or how does it work?
Well, there are some complicated logistics involved, I guess, but yes, I think what we will do in the next month, we will try to give some guidance as to how safe is safe.
Right.
I can tell you that we have looked there is this large cohort in Switzerland, a Swiss HIV cohort with regular follow-up, and so we have viral loads, and we can ask the question, well, if somebody has 2 viral loads that are undetectable, how likely is it that the next will also be undetectable?
Right.
And we don't have the data yet, but it looks like the reliability has improved considerably since HAART was first introduced.
Right.
So in 1998 or so, the probability that the next viral load had a detectable result was something like 5%, and that has come down considerably. The second impression from just looking at the data is that those who do have a detectable viral load after an undetectable are those people who have a lot of resistance and a long treatment history and many changes in treatment history, second-line therapy, and all that.
Right.
And of course, compliance is certainly a factor.
Right.
Those that miss doses and all that are of course more likely to have a detectable viral load. So I think we can give some guidelines, but we can, of course, I mean, the absolute certainty is a goal that you cannot acquire.
Expect to achieve. I've also heard that, well, let's talk about when your viral load might spontaneously come up or what might cause a blip or even, for it to rise. Vaccinations, drug resistance. What is sort of a safe interval for people to be tested? Let's say the common recommendation is if you are not sick, you haven't presented any other symptoms, and your compliance is quite good, twice a year. Most people have their lab work done, sometimes 4 times a year. Is there any reason to think that you should have your blood work done more frequently so that you can track your viral load more carefully if you were going to apply the implications of the statement?
Well, I'm not sure that there are implications that way, but so far data have been analyzed in regard to how safe is it to decrease the interval from the customary 4 times a year to maybe 2 times a year or something. There's a poster here from the Euro-SIDA cohort that suggests that you can safely go to twice yearly, that the chances to have in the interval a high viral load are really very low. So I would say that this is probably the lower limit, twice yearly right now. At least that's what we do in our practice. We usually have a routine of every 3 months, and if patients have very reliably an undetectable viral load and no problems with their meds, we go to twice yearly, every 6 months.
You all were looking at studies primarily conducted and maybe exclusively conducted, please tell me, in heterosexual couples engaging in vaginal sex. What about gay couples, and what about anyone engaging in anal sex? Is that going to change this recommendations?
Well, there are no data. You have to admit that it's speculative. Of course, one can logically assume that it would be similar because the risk of transmission by anal sex, if you take out the more traumatic practices that at times are associated with anal sex, are probably similar between anal and vaginal sex. So you would expect that the effect of treatment would be similar. But this is speculation. We don't have really good data on that.
Is there anyone planning to study that?
I think there are some studies, but I can't really quote you any such studies. So far, it has been sort of a taboo subject. The idea was you recommend condom for everybody and everything, and if something happens, it's their fault, right? I mean, that's more or less so it has been difficult. But of course, unprotected sex in patients who have undetectable viral load is largely practiced in the homosexual community, and I hope that this sort of statement will stimulate some studies that will give some quantitative answers.
Have you received any criticism for issuing this statement?
Yes. There are many people who think there are two criticisms. The first is the evidence is incomplete. It's true. The problem is that it will never be complete. The absence of a risk cannot really be proven. You can quantify the risk. You can say it is small, and you can put some zeros before the one. But how people view the residual risk is very different. Right. I think it's different in general, not only with HIV. You think about the risk of nuclear power plants. Some people can't sleep because of that, and political movements are founded on that fear, and others don't care at all. And or the mad cow scare in Europe, or the bird flu and whatever. Right. So there are these differences. They are to be expected, and they are hard to resolve. There's no right way or wrong way. The second type of critique goes this way. Well, yes, we have known that, and we tell it to patients, and when we talk to patients, we counsel them that way. But we shouldn't really talk about it in public because it will be misunderstood. Right. Now, that's another philosophical question. Do you have truth for the masses and another truth for the initiated? As a whole, I'm not quite in favor of this because in the long run that doesn't work. The information circulates, it's confusing, and I think a good public health message has first of all to be precise. And the information that treatment does not influence transmission risk is just not true, and you cannot base your public information on that.
Do you think that people will misinterpret this study and become unnecessarily infected? Is there a concern being voiced about that?
I personally don't think so, because I see that we are lagging behind what's already in the community. The zero sorting and taking and all that. Right. Many people do care about stratifying their risks, and of course the vast majority or practically all infections are transmitted by people who are not treated
or aware of their status
or ignore their status.
Right.
And therefore I think you shouldn't look at the shrub and forget the forest, and I don't think that will have much influence.
It's interesting. It's almost sort of an impetus for people to know their status, to get on treatment when it's right for them, and to maintain good adherence so that they can suppress their viral load. It gives them another option. I mean, as someone who never thought about having unprotected sex again in my lifetime because I'm HIV positive, it's a very interesting and refreshing thought to consider. So I appreciate you talking with us today very much and for clarifying this really interesting issue. Is there anything else you'd like to say on the matter? I would
add along the lines of what you just mentioned. I mean, the reaction we get from many people, and especially those that are most disenfranchised and discriminated against. For instance, the African women in Geneva, they're really the the poorest of the poor, excluded from. I mean, they are poor. They are often in difficult legal circumstances, and they are very heavily discriminated in their own community. And this sort of encouragement is felt to be very positive by them. I mean, it's part of the reason we said something publicly was also for them. I think it reinforces their motivation to get treated. That's at least what they tell us, and I think that's a good result.
Great. Well, thank you very much. It's a pleasure to have you here. Okay. Bye.
Thank you.
Thanks.